You guys can see my screen?
Yes, thank you.
Okay, great. Okay, so this is me. My daughter drew this picture for me when she was around 8 or 9. I actually don't work down at this part of the body, but this is what she wrote for me, and just wanted to share that with everyone. Okay, so what we're going to talk about are mainly guidelines, but the whole decision-making process for what to do for these patients is really important to incorporate these three things for the in a Venn diagram. First is patient values, research evidence, clinical data, and where the three intersect is what would be the optimal decision for the patient. Obviously, some of these areas that you guys have been listening to have better research evidence than others due to the prevalence of the disease. However, I think we all aim to try to incorporate as high level evidence as possible into our decision making. So this is a very important paper. You guys should all have this in your library of articles to go back to. This was the most recent rendition of the American Thyroid Association management guidelines for thyroid nodules in adult patients with differentiated thyroid cancer. And it was developed by a large task force. They did rank the evidence of each recommendation and listed it in this paper if you're interested in looking at it. It is a free article that you can access through the American Thyroid Association website. So first of all, I think the main thing that we need to talk about is when to do FNA and when not to do FNA. Obviously, we find I'm going to skip through all the other stuff in terms of prevalence of disease and incidence rates and all that stuff, but really get to the meat of the matter of how to manage these patients. So why is FNA not recommended for all nodules? Well, the main reason is what's called the Cobra Effect. This was coined by a German economist, and there was a program in colonial India which was to get rid of venomous cobras. And this sounds like a really, really good idea, right? We don't want to have any poisonous cobras lurking around our houses. But what that led to was a dramatic increase in the number of poisonous cobras that were found. And this goes to the premise of overdiagnosis. Now you can see in the first line with a red hummingbird, things that are duplicating very quickly, screening can really be effective in detecting the cancer. However, more slowly growing cancers, such as the bear or the turtle or the snail, these can render overdiagnosis, particularly if the tumor is very slowly growing and the size at which the cancer causes symptoms are a little bit at this level here. So you can see by the time you detect it, you may be detecting a non-clinically important cancer. And this is what's been going on with prostate cancer when PSA came out, and also for thyroid cancer when we started to needle every single nodule. This is what happens when you start diagnosing a bunch of little bitty thyroid cancers. You see a huge rate in incidence increase. And with the change in the guidelines, we're seeing some leveling off of these cancers instead of this high level. And this was an article that was published in Laryngoscope. So the South Korean experience really informs our decision making about when to diagnose nodules and when not to, because overdiagnosis can lead to identification of too many cobras or too many thyroid cancers that really are not clinically significant. So in South Korea, they began a national screening program around the year 2000, as you can see in this diagram, and the cases just skyrocketed disproportionately to the rest of the world. And so this was published not only in the New England Journal of Medicine, but also in the New York Times. And therefore, they found that the mortality rate wasn't really changing for these, in spite of having an increase in identification of the cancers. So that means that the patients that were being diagnosed with thyroid cancer with these nodules were really being diagnosed with non-clinically significant disease. So one of the first recommendations that was changed in 2015 was a very nuanced approach to identifying which nodule should be biopsied. And it mainly boils down to the sonographic appearance of the nodule itself, not the presence of yes or no, whether you have a nodule or not. And so here you can see that all nodules greater than 1 centimeter with high suspicion should get a biopsy. Greater than or equal to 1 centimeter with intermediate suspicion should also get a biopsy, but it's low quality evidence for this group. Low suspicion sonography should only be biopsied if it's greater than or equal to 1.5 centimeters. And things that are very low suspicion should be greater than 2 centimeters before you even consider biopsying, or you can also do another observation period to see if it actually grows. Those that are cystic or do not meet the above criteria do not need a biopsy. And so the main differences from 2006, 2009 to 2015, and these are the 3 set of ATA guidelines that are in print right now, is this big change from 5 millimeters high suspicion to 1 centimeter for high suspicion nodules. And this diagram is a great way for, I have this hanging in my clinic, to try to help correlate what you're seeing on ultrasound with what is being recommended for a biopsy. So you can see here, these are the different risk categories: high suspicion, intermediate suspicion, low suspicion, very low suspicion, and benign, and some of the characteristics. So here you can see microcalcifications. Here are some hypoechoic irregular borders, taller than wide. This one also has irregular borders, a little bit of extension outside of the thyroid capsule. This one looks like it has a lymph node over here. These are intermediate suspicion. They're solid. They have regular margins, but they're slightly hypoechoic. And then the low suspicion ones are the hyperechoic or isoechoic, which means they're the same color essentially as the rest of the thyroid gland, or a little bit brighter than the rest of the thyroid gland. Here we have some that are partially cystic with an eccentric solid area. And I'm sure you guys have seen some of these in your clinic or even on, if you guys don't do ultrasound in your office, you can see it on the radiology films themselves. Very low suspicion. You can see this spongiform, and it really does look like a sponge that's been cut in half, and you're looking at the cross section of it. Partially cystic, and so you can see the slight differences. And all of this, all ultrasound is really pattern recognition and understanding what's important and what's not important. And as you go from here to there, the risk of malignancy increases. So the FNA is reported according to the Bethesda system, and the Bethesda system was created back in the early 2000s when a group of pathologists got together in Bethesda, Maryland, that's why it's called the Bethesda system, to go through how they would standardize the reporting of these nodules. Before it was sort of haphazard. There was really no good institutional to institutional reliability or consistency, and therefore this was convened and was adopted. So basically there are 6 categories, 1, 2, 3, 4, 5, 6. And the non-diagnostic or unsatisfactory category basically means there are not enough cells, or you may have biopsied a cystic nodule and therefore you just got cyst contents. Benign is as mentioned, benign, and then malignant is as mentioned as malignant. Suspicious for malignancy is Bethesda 5, and depending on your institution, many times Bethesda 5 is sufficient to be called Bethesda 6. At my institution, for example, if I get a Bethesda 5 biopsy, I pretty much consider it as a malignant result and treat it as such. The gray areas are the 3 and 4s, which are the atypia of undetermined significance, or AUS or FLUS, and the follicular neoplasm or suspicious for follicular neoplasm. So it's important to realize that if you get one of these two diagnoses, many times they'll come to you with the fear that they actually have cancer because that is what the referring physician had told them based on the results. But that's actually not the case. It's an indeterminate or uncertain category. And so what can you do about these two groups right in the middle here? So one thing is that's come online and is becoming much more commonly available now is molecular cytology. And so what this means is that instead of just taking out the nodule, because that is what we used to do when I was in training, was if you got anything other than a benign diagnosis, you would take it out. However, we found that many of those nodules, especially if they were in the indeterminate category, Bethesda 3 and 4, that they were not going to be malignant. And therefore, there was some push to try to figure out if there's some other way that we can determine preoperatively or in lieu of surgery to predict the behavior of these nodules. Therefore, molecular testing was used to supplement malignancy risk assessment data. So the way I explain it to my patients is that it just gives us a risk idea of whether you're more likely or less likely to have a malignant nodule. But first, I think it's important to know what the statistics methodology is for these molecular testing, because without knowing the statistics, it is very difficult and you can actually mislead yourself and your patient in these results. So keep calm, it's only statistics. So I'm gonna, if the person has the disease, how often will the test be positive? Does anyone want to venture a guess or an answer to what this is? Which A, B, C, or D? I can't really see the chat box. So it's, oh, here we go. Let's see. A, very good. Okay, now I can see my chat box. I'm gonna put it over here. It is A, it's sensitivity. If the person has the disease, how often will the test be positive? Okay, next question. Hold on one second. If the person does not have the disease, how often will the test be negative? Specificity. Let's see if you're right. Yep, it's B, specificity. So these two are important statistical criteria by which to guide the how good the test is for your population. And especially with this SARS-CoV-2 CoV-2 testing discussion in the media right now, it's also very important to understand what the testing results are for these different tests. So what is the thing called if the test is negative, what is the probability that the patient does not have the disease? This is called the negative predictive value, okay? So this is very, very important. So if I get a negative result, how good can I, well, how much can I take it to the bank, essentially? Am I really negative? And many of our tests are good in the positive predictive value, which is the opposite. If the test is positive, what is the probability that an individual has the disease? So to bring it back to current events, if you have a test that's COVID positive, you're pretty well assured that you are positive, that you have the disease. However, if you're COVID negative, you still could have the disease because the negative predictive value is not very good for the current testing that we have right now for a variety of reasons. It may not be the result of the test itself. It might be the result of obtaining the specimen, i.e. the needle biopsy and or the nasopharyngeal swab. So these are all things that are very important to consider before you run out and do a bunch of tests and bank on it. So the molecular diagnostics that are available, there are many, many, many available, but I'm just going to talk about a few of them, which are probably, these are probably the most commonly used ones right now. And I should say that I have no disclosures. I am not on any sort of speaking board for any of these companies. So a rule out test means that it's a high negative predictive value. So if you have a negative test, you can rest assured that you are most likely going to be negative. And the Afirma test is one such test. A rule in test means that you have a high positive predictive value. The Thygen X is such a test. And something that has both high negative predictive value and high positive predictive value is really what you want. And that is why I personally chose to use the ThyroSeq in our clinic. When I first started doing needle biopsies, I was using Afirma and realized that we were not getting a lot of good results because we're getting a lot of negative results. But then once it became positive, then I wasn't sure what to do with the information. And the ThyroSeq just gives us a little bit more granular information. So it's important to understand also the other part, not only sensitivity, specificity, positive predictive value, and negative predictive value. It's also important to understand what Bayes' theorem is. And it is a statistical technique that allows us to calculate the probability of disease given the result of an imperfect test. We're never going to have a perfect test, and that's just something that we need to acknowledge and accept. But it's also very important to know what the probability of disease is, i.e. the prevalence of the disease. So in our case, it's thyroid cancer prevalence. And this has the sensitivity and specificity of the test and how it performs is related to the prevalence of the disease. So minimize this. So the Bayes' theorem permits a calculation of the probability of disease given a positive or negative test given the prevalence of the disease. And I'm going to show you some diagrams to better illustrate this. So basically, if you are in clinic A or setting A or geographic region A, and the prevalence of disease for thyroid cancer, if you have a Bethesda 3 or 4, is about 30 to 40%, then you can see that the positive predictive value is about 57%. Negative predictive value is pretty high. And as you move along this x-axis based on prevalence of cancer, you are going to change your positive predictive value and your negative predictive value. So if you're in clinic B, where if you very seldomly do does a indeterminate nodule turn out to be cancer, therefore the prevalence of this is very low, your positive predictive value is really going to only be 6%. Your negative predictive value is going to be much, much higher. And this means that most likely you are calling too many indeterminate nodules and not enough one way, benign or malignant, one way or the other. And so this demonstrates Bayes' theorem in that if you move along the x-axis, you're going to change your negative predictive value and your positive predictive value. So what I'm trying to get at is wherever you are in residency, or where you go to fellowship, or you go into private practice, or you go into any sort of academic practice or community practice, it really doesn't matter where you end up. It's very, very important to know what your pathologist and cytopathologist results are and what their prevalence of cancer rate is in the nodules that are determined to be indeterminate on their initial cytology. So how do these tests work? Well, here are the 3 tests that I just mentioned: Afirma, ThyroSeq, and Thygen X. Basically for Afirma, it's an expressive analysis of mRNAs. You usually do 1 or 2 FNA passes, and then you put it into a special vial that needs to be sent directly to Afirma. And then for ThyroSeq, it's DNA and RNA. They compare it against a bunch of different genes for mutations, gene fusions, and gene expressions that have been previously identified to be associated with a malignancy. And therefore, you're just comparing what is seen on the FNA versus what is seen in the data set or in the data bank to determine what the risk of malignancy are. Again, this is the same thing. You do a FNA passes, you go ahead and you save it into this special vial with a nucleic acid preservative, and you send it to ThyroSeq lab for them to run it. The cytology review is local or centralized. At my institution, we do the analysis of the cytology in-house, and that is a determination that you have to do with ThyroSeq. If they feel confident in your in-house cytology review, they will allow you to do cytology review at your own institution rather than having it be sent to them for them to review it. And the way that I do it is that I collect the specimen with every biopsy that I do, and we save that little vial. If it turns out to be a Bethesda 3 or 4, then we have the vial be mailed to ThyroSeq or to Afirma. It was the same way I did it, both the same way for either company. If it turned out not to be a 3 or 4, then every 30 days, those vials would be discarded by pathology. And that was the system that we had worked out. Again, ThyGenX is very similar. It also uses gene fusions and gene mutations to indicate a risk analysis. And what we see here is that if you look at the red box, sensitivity, specificity, negative predictive value, and positive predictive value, if you want to try to balance the high sensitivity with high specificity, high negative predictive value, and high positive predictive value, it's probably going to be either the second or the third column, not really the first column. So molecular cytology is just another tool in your toolbox for figuring out these indeterminate nodules. However, you do need to take into consideration ultrasound findings, clinical presentation, and the history of present illness to be examined as a whole. I can't tell you how many times I've taken a patient to surgery, or I didn't take a patient to surgery because of the cytology, and forgetting to incorporate everything together, because some of the weird looking nodules that just, there's no way this could be benign, or there's no way this could be just indeterminate, really did turn out to be quite bad actors. And just to remember that this is just another tool in our toolbox. So now that you have a diagnosis of cancer, what's next? I'm going to go ahead and move on to what we need to do once we have a diagnosis of thyroid cancer. So the first important thing to do is to do an ultrasound. This is very, very important. Just because the patient comes to you with an ultrasound does not mean that a neck ultrasound was performed. There's only one CPT code for neck ultrasound, and most of the time the radiologists only concentrate on the thyroid and not look at the lateral neck or the central neck. So if you are at such an institution, then it's important to go back and ask the radiologist to do a lateral neck ultrasound, or to do one on your own in the office. And this is very important to screen for malignant or suspicious appearing lymph nodes in the central or lateral neck. And if you do find something that is sonographically suspicious, then you should go ahead and biopsy it. There are some payers who will refuse to pay or approve a neck dissection 38724 CPT code unless there is biopsy proven thyroid cancer in that neck. So here is an example of a ultrasound. Here's the lymph node that's popping up, and this is the vein here. And so you can see that there is definitely a lateral lymph node that needs to be biopsied. Here's another moving ultrasound. You can see, again, here's the SCM, and here's the vein with the artery, and you can see a little lymph node right here. When do you use cross-sectional imaging? Well, obviously, IV contrast can inhibit the role of RAI postoperatively, But in this day and age, most of the time, the intravenous contrast is of a type that is very rapidly cleared, and also they tend to use a lower dose these days. So I don't hesitate to use CT with contrast, especially if I'm worried about advanced disease. And how do I determine whether there's advanced disease? Well, if there's a vocal cord out, then I know that there is some invasion of the tracheoesophageal groove, and that might prompt me to get a cross-sectional imaging. If there's lots and lots of bulky disease in the neck, if there's concern for any other invasion of the aerodigestive tract, such as the patient presents with hemoptysis, that might indicate tracheal invasion, and that would be a good patient to consider a cross-sectional imaging on. What about PET? PET is really not recommended routinely, preoperatively for these patients, and there's really low quality evidence, and many times it's not even recommended. Now remember, we're talking about well-differentiated thyroid cancer in this talk. Anaplastic and medullary are a different talk altogether, and perhaps at some other time in this rotation, if we're still in this pandemic, I'd be happy to come back and give a talk on those two topics as well. So CT scan with contrast is very good, as I mentioned, for looking at tracheal invasion, also subclavicular invasion of lymph nodes and or the thyroid itself. It's also excellent for looking at retropharyngeal adenopathy. This is an area that often is overlooked or forgotten when radiologists look at cross-sectional imaging. I also forget sometimes to look at this area because, especially in young patients, they tend to have a lot of disease that tracks up from level 2 to B and then tracks up along the retropharyngeal region to end up in adenopathy. And this is really hard to treat without surgery. You can't really get to it. Otherwise, it's not likely to resolve with RAI, and therefore it's very, very important to identify this preoperatively so you can get it. Obviously, mediastinal disease is something that you cannot appreciate with ultrasound, and a cross-sectional imaging can help you identify this and can also help you plan to see if you need the help of a thoracic surgeon to split the sternum, for example. Preoperative voice assessment is very important. I won't belabor the point since we're all on the same team here. If I give this talk to a combined audience, I usually spend a lot more time talking about voice assessment. So one new thing that I think is important to talk about is active surveillance. There was never any discussion of active surveillance when I was in training or fellowship. And until a few years ago, there really was not much talk about active surveillance. And what does this mean? It means that you know that a patient has biopsy-proven thyroid cancer and you're not going to operate on it. And there are a variety of reasons of why this can be an okay reason. One is that they have a very low-risk cancer, for example, a papillary microcarcinoma with no clinically evident metastasis or local invasion. And it's located in a favorable part of the thyroid. Those who are at high surgical risk because of comorbid conditions. For example, I'm following I think he's like 90 or 92. I started following him when he was 88. He's a very nice man who just doesn't want to have any sort of surgery to his thyroid. I see him every year. We monitor it, and it hasn't really changed all that much, and he's very happy with the current plan. And although he does, who knows when his lifespan may be abbreviated. However, those with high comorbidities and with bigger fish to fry, so to speak, probably should have their smaller thyroid cancer, which is less morbid and less mortal, to go ahead and be observed. And those that have medical or surgical issues that need to be addressed prior to thyroid surgery, such as a concurrent, more malignant cancer process, or other sort of medical illnesses that need to be treated first. So where did this all come from? Well, there was an observational trial for papillary thyroid microcarcinoma in Japanese patients. This was published in the World Journal of Surgery. And what they did was they did a randomized, actually this wasn't randomized, but they just observed the patients who had microcarcinomas and see how they did. They decided not to operate on them. This was an institution-wide study. And this was conducted between 1993 and 2004. Patients with sub-centimeter papillary thyroid cancers diagnosed by ultrasound-guided fine needle biopsies were offered observation versus surgery. If they were observed, they were examined every 6 to 12 months with ultrasound. If there was more than a 3 millimeter growth in any dimension, then surgery was offered. 340 patients underwent observation. About a third of them subsequently had surgery. There was no recurrence after their surgery. About 1,000 or so underwent immediate surgery. 46% of them were lobectomy. And there was what was really interesting was that there was no detriment of delayed surgery in the observation group. So if you just watched it until it grew, then did the surgery, there was really no adverse outcome in waiting. So these authors, Dr. Miyauchi, Ito, and Oda, went back a few years later, about 10 years later, this was published in 2018, and said, okay, guys, this is what we learned from this experience. And so there are some high-risk features that should not be considered for active surveillance. Obviously, if they have nodal disease or metastatic disease, they should not be observed. If there are signs or symptoms of invasion to the recurrent laryngeal nerve or trachea, so hemoptysis, hoarseness, signs of vocal cord paralysis by your examination, either by ultrasound or by nasopharyngeal laryngoscopy. If you get a high-risk malignancy on cytology, now that's pretty rare to find. It's really difficult to tell tall cell variant PTC, hobnail type of PTC on cytology, and therefore that's very rare. If there are progressive signs such as size enlargement or development of lymph node metastasis, so that reminds me to inform all of you that when you're doing surveillance of these patients, it's not just important to look at the thyroid itself, you have to look at the lateral and central lymph nodes. And other contraindications for active surveillance are that features that are unsuitable for observation. For example, if it looks like that the tumor is very, very close to the trachea or the recurrent laryngeal nerve, perhaps you should not observe it, because once it breaks through or once it grows, there's not much room for it to go except into the trachea or the nerve. So this was their proposed algorithm. If you have a papillary microcarcinoma, and you first determine whether they have high-risk features, no, then you can do active surveillance. If the patient agrees, then you follow them with ultrasound on the left side of the table. Once you continue to survey them, unless they get tumor growth and or nodal metastasis, then you go back to surgery. If they do have high-risk features, so on the right side of the table, then you should consider them for surgery. If they are eligible for surgery, then you just do surgery. If they are not eligible for surgery for whatever reason, because of comorbidity status or other reasons, then you can consider active surveillance. You can also consider supplementing with LT4 for suppression. However, that's not been proven to really have much of an impact. So what did they found at Kuma Hospital and the Cancer Institute Hospital? Basically, of the 1,235 patients at Kuma Hospital, 8% showed a size enlargement and 3.8% showed novel node metastasis at 10 years. So this is for some of these patients, this is a very slow growing cancer. In addition, none of the patients who underwent surgery after the detection of progression showed significant recurrence or died of PTC. So again, demonstrating the no loss of value with surgery after observation. And the costs are that the total cost of immediate surgery was 4 times the total cost of 10 years of management of active surveillance. And the Cancer Institute Hospital showed similar findings as well. So what is the, if you do have a patient with a small papillary microcarcinoma and they ask you, hey doc, what's my risk of it growing? What's going to happen? Can you tell me? Obviously we can't know for sure, but those who are younger actually have more growth. Those who are older tend to have less growth in terms of disease progression. However, I always try to tell the patient, just like the stock market, past performance does not predict future returns. So just because it's growing at a certain rate for the past year or past 2 years does not mean it's going to grow at that rate in the future. And that is the conundrum that we're in. So I think I like this cartoon. Although it's nothing serious, let's keep an eye on it and make sure it doesn't turn into a major lawsuit. And I think that this is something that's always in the back of my mind. When a patient agrees to active surveillance, I actually have them sign a consent form, much in the same way as if they were consenting to a total thyroidectomy or hemithyroidectomy. And that just helps, not so much to cover my butt, but more so that the patient understands the magnitude of their decision, that they're choosing something that's just as impactful as having surgery. So if we look at the changes in ATA guidelines from 2006 to 9 to 15, in the old days, pretty much if you had any sort of biopsy-proven thyroid cancer, your whole thyroid gland came out. Rarely did we do lobectomies, and really active surveillance was not even on the table. In 2009, we became a little bit more nuanced. If the thyroid cancer was greater than 1 centimeter, once again, we went ahead and did a total thyroidectomy. And we only recommended a lobectomy if it was a micro PTC and if there was no lymphadenopathy. Again, active surveillance was not on the table. The most recent rendition, we've become much more conservative, if you will, with regards to recommending surgery, total thyroidectomy or lobectomy for those between 1 and 4 centimeters. And lobectomy can even be considered for those nodules that are less than 4 centimeters with no evidence of extrathyroidal extension or nodal metastasis. And then we just went through the whole discussion about active surveillance and how that is included in the ATA guidelines. So moving on to what is next for the central lymph nodes. Should you do a central lymph node dissection or not? And I think that this is where we don't have great evidence. We have low quality evidence for prophylactic central lymph node dissection. Now we tend to recommend it just for larger tumors such as T3 or T4. Particularly if they have lateral disease or if you need more staging info. You can not do, it's okay to not do a central lymph node dissection. If it's a smaller primary tumor, such as a T1 or T2, it's non-invasive and there are no cervical lymphadenopathy. And this would apply for most follicular thyroid cancers. So here is the central lymph nodes where they reside next to the trachea itself. Here is the left recurrent laryngeal nerve. Here's the right recurrent laryngeal nerve. You can see all the soft tissue that's been removed off the anterior wall of the trachea, all the way up to the thyroid cartilage. And this is the changes over the 3 guidelines. So initially in 2006, it was indicated for patients with papillary thyroid cancer and Hürthle cell cancer. So if you had a 1 centimeter thyroid cancer patient and you sent the patient back to the endocrinologist, 8 times out of 10, I would get a phone call from the endocrinologist saying, hey, you didn't dissect the central lymph nodes. And then I would have this discussion of, well, yeah, but I don't really think that it's necessary. It's a very low risk tumor. And doing a central lymph node dissection can has its own share of complications, which doesn't really outweigh the benefits of doing a central lymph node dissection. And then they would reference this guideline, 2006 guideline, but it says that you're supposed to do it. And so it became sometimes an area of contention for the surgeons and the endocrinologists. So in 2009, it became a little more nuanced. The language became may be performed rather than is indicated. And it was really just for larger tumors. And now in 2015, it's even more specific in saying that it should be considered with large tumors involved lateral cervical lymph nodes and to guide further treatment. So we've changed a bunch between 2006 and 2015. So what is the evidence for doing it and what is the evidence for not doing it? Obviously, if you do have lateral lymph node disease, you should take out the central lymph nodes. And if you have central lymph node disease that look enlarged, and that is something that you can usually tell on ultrasound, although if it does creep up behind the sternum, you're not going to be able to see it on ultrasound, and you may need to get cross-sectional imaging to do that. And so we've already talked about the larger tumors and clinically enlarged lateral lymph nodes. But there is a big bear that is going to try to frighten you if you do central compartment lymph nodes. And that is, one of them is the recurrent laryngeal nerve. And you can see it here draped along the tracheoesophageal groove. And the reason for being careful and intentional about whether to do a central lymph node dissection is because lymph node disease in the central neck is common. If you remove lymph nodes, you are probably going to find some that contain cancer. I've seen many pathology reports where they say lymph node involved with papillary thyroid cancer, the focus is 0.1 millimeter. And then I'll call the pathologist and say, are you sure it's 0.1 millimeter? And they say, yeah, it was 0.1 millimeter. So it's like tiny, 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 tiny. And just because you see it pathologically doesn't mean that it's going to be clinically apparent. And therefore, you're going to end up with 1 out of 2 lymph nodes positive. Well, that 1 out of 2 lymph nodes being positive in the central neck is really 0.1 of a millimeter. So that's what I'm getting at. Which nodal disease is clinically significant? Did I find the disease versus did I help the patient? Now, if I took out that 0.1 millimeter 0.1 millimeter focus of papillary thyroid cancer in a lymph node and also took out 4 parathyroid glands, I certainly didn't help the patient, because not only did I not help them with their cancer control, I did not help them with their hypoparathyroidism. So not all nodal disease has the same significance. Obviously, the 0.1 millimeter focus in a lymph node is not really clinically significant, as there is with extracapsular spread, for example, of cancer outside the lymph node. And these little bitty things really have no impact on recurrence. The higher risk do have higher levels of recurrence. This is hard to study in large population-based studies because the CAP protocol for reporting pathology doesn't really comment on the size of the focus of the cancer in the lymph node. But these are all mostly single institutional or a few retrospective studies. But what is the best data we do have? There is one randomized control study where they did look at, in one single institution, they looked at prophylactic versus not prophylactic. 50% had micronodal disease, so therefore very, very small focus of disease. There was really no difference in outcome with persistent or recurrent disease. So still very low, but we really aren't helping the patient all that much because we really didn't have any difference in outcome. However, this was the big change, that there was a much higher rate of permanent hypoparathyroidism in about 20% versus 8% of those who did not get a central lymph node dissection. Now, I'm sure there are some of you who are thinking, no way, you know, our surgeons are much better and we don't get that sort of rate of hypoparathyroidism. But anytime you start to dissect and devascularize the soft tissue in the central compartment, you run the risk of permanent hypoparathyroidism. And if you have an 18, 20, 22-year-old patient, that can be devastating. So I think it's very important to be, again, intentional and thoughtful about whether you're going to do a central lymph node dissection or not. So, so basically, here's another study that looks at, there's no difference in local regional recurrence. There is a higher rate, again, so this study corroborates the previous study. And it did upstage the patients and increase the use of RAI. Now, RAI is thought to be a pretty benign procedure. However, it has been linked to second primary cancers. It can also cause xerostomia. It renders the patient infertile for at least a year or so. And so it's very important to consider the use of RAI and the appropriate use of RAI. So reasons not to do a prophylactic central lymph node dissection is clinically significant disease can be picked up by high quality ultrasound and a high quality ultrasonographer. And therefore to target the clinically significant disease is important. Lymph node disease not captured on ultrasound is most likely not significant. But again, you are relying a lot on your ultrasound and your ultrasonographer. Microscopic disease does not increase risk of recurrence. And it can double the risk of transient or permanent hypoparathyroidism for patients. This rate probably changes according to the volume of the thyroid surgeon. However, it still increases it, regardless of whether you say it doubles or it increases by 25%, it does increase it. The special situation for doing a central lymph node dissection without gross evidence of central lymph node enlargement may be a tall cell variant PTC. And central lymph node status does have a prognostic value in this study that was published in the Annals of Surgical Oncology. So basically, if you weigh the risks and benefits of doing a central lymph node dissection, the benefits are that you can get more staging info. In some cases, you can decrease the thyroglobulin postoperatively, can help you guide the need for I-131 after surgery, and it can help with some disease-free survival, although the data is not robustly significant. The risks are bleeding, hypoparathyroidism, and recurrent laryngeal nerve injury. So when do we dissect the lateral lymph nodes? The lateral lymph nodes should be dissected for only in those cases that are clinically node positive. And that can be, and as I mentioned, there are some payers who insist that a biopsy be performed before they will approve 38724, which is a CPT code for modified radical neck dissection. However, in many cases, just the appearance of the enlarged lymph nodes with hypoechoic features or with microcalcs in them, they're very typical appearance for clinically significant lateral lymph nodes on ultrasound. There's really no significant changes from 2009. The 2015 guidelines do discuss a little bit more about the significance of microscopic versus macroscopic disease. However, this doesn't really impact your initial decision-making because you're not going to know whether it's microscopic or macroscopic disease until after you dissect the neck. So for advanced thyroid cancer, once it gets out of the bag, so to speak, surgery for the aerodigestive invasive disease is recommended if you can do it. And I think that this is something that we discuss at Tumor Conference quite a bit. You know, is it worth it to do a tracheal resection? Is it worth it to do a laryngectomy? And I think that in many cases, if the patient is eligible for the surgery and can handle the surgery in terms of performance status and other comorbidities, and the patient is willing to undergo the surgery, then I think it's a very good way to render the patient disease-free. Now, when do we do systemic therapy? Again, that's beyond the scope of this talk, and multi-kinase therapy is actually something that has been studied, and there's a whole slew of other medications that can be given. I point you to this paper here. This was an American Head and Neck Society consensus statement on management of invasive well-differentiated thyroid cancer. And it's a very, very, very good paper because it outlines a lot of the features that we confront. So I have a few minutes here to talk about advanced thyroid cancer, and we'll go through this real briefly. And so what do I mean by advanced thyroid cancer? What I mean is involvement of the recurrent laryngeal nerve, involvement of the trachea, esophagus, or larynx. So starting with the first one, recurrent laryngeal nerve injury. When do you decide whether to resect or preserve the nerve? The things that make us try to resect the recurrent laryngeal nerve is that we know that there's a higher local recurrence with gross residual disease. However, unfortunately, in spite of resecting the nerve, and we're thinking that we're doing much better in terms of removal of disease, there's really no difference in survival. And it's also very important that if you do resect it, you should re-anastomose it immediately or do a nerve graft for repair. A delayed anastomosis or delayed repair is usually not as efficacious as one that's immediate. And here is the, here's a rendition of the tumor. You can see the large bulky tumor, and here's the nerve. Obviously, this is a tumor that is going to be very, very difficult to peel off this nerve. Even if you were to peel it off, you know that you're leaving behind macroscopic and or microscopic disease. Again, you can see this whole tumor here that's, you have normal nerve and then this big tumor. And so it's a big problem here, and most likely this nerve is already non-functional. What about if it involves the trachea? Now, a patient can present with hemoptysis, and I've had several patients present with hemoptysis and not realize that they actually had tracheal invasion of their thyroid cancer. And you can see here that the nice lumen of the trachea has been distorted with this invasive process here. And what it looks like is that you can actually see tumor going into the tracheal wall, growing through and through the tracheal wall. So this is an intratracheal examination. And I know that this is not a picture of tracheal resection of a patient with cancer. However, it's the same phenomenon where you take out the segment of the diseased trachea and re-anastomose it primarily. And that is my favorite approach to removal of the trachea that's involved, rather than just leaving it behind, because that doesn't bode well, and you're not going to improve the patient's survival by just leaving it behind and hoping that RAI or radiation will help you. There is a higher recurrence rate with a shave resection and leaving the trachea behind, higher morbidity of the resection. And I would have to say that my only disclosure is that I am an otolaryngologist, head and neck surgeon, not a general surgeon, and therefore I have much more of an appreciation for the trachea, and therefore I'm much more comfortable with resecting the trachea than perhaps someone who may not have as much training during their residency or fellowship. Esophagus. So the esophagus is right back here. You can see that this tumor does involve part of the esophagus. Many times the patients are complaining of some dysphagia. I think that this can be very difficult to tell on imaging, and even here you can just see that there's fullness there. It's hard to tell whether there's direct involvement of the esophagus itself. Things that I have found to be helpful is placing a Maloney dilator in the esophagus at the time of the surgery, so that you can use it to dissect the muscularis layer off the Maloney dilator, leaving behind the mucosa of the esophagus so that you don't get a perforation. If you do have intraluminal invasion, of course you have to resect it and do a primary closure or do a flap. And I think that in my experience, intraluminal invasion is pretty rare. The muscle actually serves as a protective layer into the to the esophagus. Larynx, here is a patient that we actually had to do a trach on because the mass had distorted the trachea all the way over to the right. This really was where his trachea was. It isn't that we didn't know how to do a trach and put it over to the right side of the neck. This whole mass here is the tumor. And sometimes we have to do a laryngectomy on these patients. This is a patient, I don't know if the audio will play. Let's see.
Friends, Romans, countrymen, lend me your ears. I come not to praise Caesar, I come to bury the poor dude. Family God 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. And this day hands free, and it's working really good for me today. I hope it works just as good tomorrow.
So you can have a really good result with a total laryngectomy and a primary or secondary TEP, as this patient demonstrates. There are complications with doing this type of advanced surgery. Obviously, there are cranial nerve palsies, going to get a hematoma, a chyle leak. Wound complications, carotid rupture, luckily is not very common, and you can actually have tracheoesophageal tears that were unidentified or unrecognized during the intraoperative period. Here's some good pictures of what a cranial nerve 11 palsy looks like and what a 12 palsy looks like on the left. Chyle leak, I hate chyle leaks, the bane, they're awful. They usually happen on the left side of the neck, although I've had them on the right side of the neck as well. And as you all know, it's because of the thoracic duct being really, really close in proximity to the vein. This is exactly where we're doing the lateral neck, the central neck dissection, the dissection of the lymph nodes around the thyroid cancer in the level in the supraclavicular triangle. This is where the lymph nodes in thyroid cancer like to hide. And that's why I think that we encounter this thoracic duct so much more commonly in thyroid cancer neck dissections. So in summary, for this first hour, we've discussed the indications for fine needle biopsy of a thyroid nodule, discussed molecular diagnostics of FNA, discussed indications for active surveillance, and discussed when to take out lymph nodes, both in the central and lateral compartment, and briefly discuss the surgical management of advanced well-differentiated thyroid cancer. Lastly, I want to emphasize the very important role of a multidisciplinary approach to these diseases. You must include the patient and family members. It's very important to have regular conferences with your endocrinology colleagues or radiology colleagues. At our thyroid tumor conference, we have radiology colleagues from neuroradiology, from nuclear medicine, from ultrasound or body radiology. So and our pathology colleagues. Many times we have to discuss with them about differing types of cytology reports or pathology that we see. So in summary, the good physician treats the disease, the great physician treats the patient who has the disease. And I think this is something that we all need to remember as we move forward. Thank you. I'll take questions now via the chat if you all have any before we move on.